Assalamu alaikum. Bismillahirrahmanirrahim. I'll be talking on keratoconus and how to improve your visual outcomes if a patient of keratoconus comes to you. Keratoconus, as we all know, is a bilateral, non-inflammatory, progressive corneal ectasia and is characterized by corneal thinning, protrusion, and progressive myopia. The biomechanics of keratoconus is the corneal stress is driven by thickness of the cornea, and the greatest stress is at the thinnest pachymetry and also at the maximum curvature. The maximum stress moves away from the thinnest point once the keratoconus progresses, and this stress moves around the cone or around the thinnest point. And severity of the keratoconus depends upon the difference between maximum and minimum stress. The stress means the force per unit area, and strain means the percentage change in length. Now, what I talked about was that the maximum stress is at the thinnest point. And once this keratoconus occurs, this stress is transferred from the central point to the around the central point, around the thinnest point, and this keeps on progressing, and keratoconus keeps on progressing, and until the hydrops occurs. So, what are the options? The options are corneal cross-linking, or Athens protocol, or intracorneal rings, depending upon at what stage the patient is coming. The most important thing before treatment is that keratoconus should be diagnosed as early as possible. So we don't have to wait for that coning will occur, or we'll see the box tria, or we'll see the Fleischer ring, but we have to look, we have to diagnose it before these changes occur. So we have to keep an eye on many things, like we have to keep an eye on the posterior elevations. We have to keep an eye on posterior elevations changes that are the earliest signs of, one of the earliest signs of the keratoconus. The Bellin embryosio ectasia chart also helps us differentiate between normal and abnormal shape. The other thing that is very important in diagnosing early keratoconus is corneal thickness spatial profile and percentage tissue. Percentage thickness increase in that assesses how the thickness is distributed over the cornea and how these changes progress compared to the normal population. The other thing very important is epithelial thickness mapping. This helps us differentiate between keratoconic cornea and corneal dryness, and in the normal patient with the normal rubbing, the patient who is rubbing the cornea. So we have to differentiate between these all present like keratoconic topography. So the first thing we offer to the patient is corneal cross-linking if other options cannot be tried. So what do we do in this corneal cross-linking? It helps to stabilize the weak cornea, and it reshapes the cornea over time. But there is no advantage in optical quality until it reshapes the cornea. In Athens protocol, we ablate the superficial stroma to regularize the surface cornea in addition to epithelium of CXL. Then main advantages in addition to CXL is it enhances the optical quality. It redistributes the stress from the cone to, and it prevents progression, and it improves the contact lens tolerance. The protocol begins with, we do a PTK of 9 mm area to remove 50 mm of the epithelium. Then before topography, then perform the topography guided partial PRK. Then we apply mitomycin C. Then we do CXL procedure. And we do the CXL procedure. In intracorneal rings, we place 1 or 2 rings inside the cornea to manipulate the corneal curvature. The main advantage is, in addition to CXLR, it also improves the optical quality. It redistributes the stress from the cone and prevents progression, and improves the contact lens tolerance. Now, this is a case of, now you can see there's a cone there. This is the protrusion, but there is a flat area also here. And in this case also, again, you can see there is the protrusion, there is a cone here, and there is a flat area also. So if we want to treat this area, we not only have to treat the cone, that is, we have to hammer out the cone to reduce the bulge, but we have to elevate this area also. So in Athens protocol, this is a bimodal treatment. It is a myopic treatment here. It treats it hammers out at the cone, and there is a myopic treatment, and it elevates the flat area, so in the right eye, in the left eye. And you can see in a year's time, you can see the Kmax went down from, I can't see exactly here, but you can see, if you can see that it went down from here to here in 1 year's time, in right eye, in left eye. And also, and you can see here that the initial refraction of that patient in right eye was -6 cylinder, and in left eye also -6 cylinder. That went down to, in a year's time, to -3 cylinder and -3 cylinder. And the K1, K2, you can see that this was the pre-operative, and these are the one year post-operative. So this is how it helps in patients' rehabilitation of the visual acuity. And this is case 2 for, he underwent this keratoconus, this underwent the intacs, the intracorneal rings, and this is how in 3 years' time you can see the change that has occurred in the K readings, and this is how you do a femto-assisted intacs. ये जरा चलाइए भाई. एक मिनट ठहरिएगा. We are creating channels through the femtolaser assisted channels for the intacs. Okay. Quick. नहीं चल रहा है. You can notice that we have marked it in the center of the pupil so that the rings will be implanted around this. This is how the channels are created. We're just opening the channels, and then we'll implant the rings in. And if Acha, do we have a final picture?
Yes. This is
The rings in the This is the final picture. You can see the rings here, the implanted rings here, and you can see on this B scan. So this is how it stretches the cornea, and so it depends upon at what stage you are getting the patient. If if it allows, then this is one of the methods that helps patient wear the contact lens, and the other one, the Athens protocol. If the tissue is enough, we can do the partial PRK with CXL, and we can make the patient glass free also. The third one, the first one, if tissue is not there, we can only do the CXL only. So मैं पेशेंट को इस तरह से समझाता हूँ कि अगर आप CXL कराते हैं तो ये ऐसी बात है जैसे हमने एक गाड़ी में डेंट लगा हुआ है ऊपर एक कलर कर दिया, और अगर आप चाहते हैं कि आपका डेंट भी निकले और आपका कलर भी हो ताकि आपकी विजुअल क्वालिटी अच्छी हो, तो फिर आपको एथेंस प्रोटोकॉल की तरफ जाना चाहिए. तो जो मैं एथेंस प्रोटोकॉल सिंस लास्ट 10-12 ईयर्स से कर रहा हूँ, इसके रिजल्ट्स बहुत अच्छे हैं. द ओनली थिंग that I had the problem of is that of haze. At times it creates problem. But if we take into consideration pre-operative management of that particular patient who is undergoing a CXL, and we are treating the dry eyes nicely, then I don't think you will get any haze post-operatively. Thank you very much.
Next talk is by Dr. Mahfouz Hussain. Is he around, Dr. Mahfouz? I don't think he's around, so the next speaker would be Noman Hashmani. He'll be talking about solving dry eye conundrum.
Assalamu alaikum. First of all, thank you for inviting me. I wanted to talk about this topic, which is one of the most misunderstood topics in ophthalmology, I feel. And I'm going to speak about how multimodal imaging can help in diagnosing these cases. So I'm not going to spend too much time on this. Everyone knows that the lipid, aqueous, and mucinous layer is part of it, but we need to realize how common dry eyes is in our population. We did a study about 2 years ago, and we did in about 2,500 cases, and we did OSD. We added in OSD and all of these people, which is a quality of life questionnaire, and we got a cutoff of 43.6% of people have some sort of dry eye, and after ocular factors were removed, we have about 33. So everyone sitting here, 1 in 3 people have some sort of dry eye disease. And this is comparable to everywhere. We have slightly higher than most places in the world. And this is the ocular surface disease questionnaire, which divides these questions up, and it tells you, and it helps you categorize ocular surface disorders in these mild, moderate, according to the patient's symptoms. And then that helps you, because it's so simple, it then helps you see who needs to be treated and who you need to focus on. Then from